Namaskar, dosto. I'm Purnima from Fertility Dost, and welcome once again to this wonderful platform known as Fertility Dost. So, किसके बारे में बात करना चाहेंगे आज? हमने सोचा आज बात करते हैं सिस्ट के बारे में एंड दिस इज जस्ट अ कॉमन वर्ड व्हेनेवर एनीबडी से सिस्ट तो हम कहते हैं ओह ओवेरियन सिस्ट and we just ranting about the whole procedure cyst ऐसे होता है पीरियड फ्लो आएंगे खत्म हो जाएगा अरे घबराना मत सर्जरी मत करवाना अगर डॉक्टर ने बोला कुछ गड़बड़ हो जाएगी ओवरी खराब हो जाएगी बट हैव यू एवर थॉट कि ये सिस्ट है क्या सिस्ट इज दिस मच नहीं नहीं इतना जितना मैंने बताया उतना नहीं इट्स लाइक छोटी सी चीज है इट कुड बी सॉलिड इट कुड बी फिल्ड विद फ्लूइड it could be on the surface of ovaries or it could be within it, the ovaries. So अगर ये cyst है तो is it really harmful for you? कहते तो ये हैं कि अगर ये cyst disappear हो जाए it is good but if it persists it's always advisable to consult your doctor. So when I was just reading about this cyst तो मुझे बहुत इंटरेस्टिंग सी एक चीज पता चली कि हमारे इंडिया में it's like more than 10 million cases of cyst every year. I don't know whether it's true or not, but Google ने मुझे यही बताया, so I believe. और मैंने सोचा चलिए इसको कुछ कंफर्म कर लेते हैं कि ये सच में ऐसा है कि नहीं तो किससे कंफर्म करना चाहेंगे आप और हम आज मिलके बात करेंगे डॉक्टर इमराना से बहुत सारे लोग यहाँ पे ऐसे हैं जिन्होंने हमें बोला कि मैम प्लीज जस्ट मेक श्योर कि वील हैव अ चैट विद डॉक्टर इमराना सो वी जस्ट थॉट अबाउट हर एंड उनसे हमने सोचा बात करते हैं कि सिस्ट एग्जैक्टली है क्या और सच में क्या इतने लोग इंडिया में इस सिस्ट को झेल रहे हैं और झेल रहे हैं या झेलना शुरू कर रहे हैं जो भी है और सबसे इम्पोर्टेंट बात यहाँ पे क्या ये सिस्ट ही ऐसा है जो हमें फर्टिलिटी डॉक्टर के पास विजिट करवाता है क्या यही वो कल्प्रिट है अगर है सो व्हाट वी कैन डू अगर नहीं है तो just relax. So, viewers, just start pouring your questions, your doubts related to cyst, and let me call our chief guest, doctor, on the main screen. Yes, sir. Good evening, Dr. Imrana.
Good evening. Thank you once again for the honor and for the love.
Thank you, ma'am. So, viewers, we have Dr. Imrana with us. She's director, she's fertility specialist, and she's endoscopic surgeon from Janm IVF भागलपुर. बहुत सारे सीरीज किए हमने बहुत सारे लाइव किए और इनको यहाँ तक हमारे प्लेटफॉर्म पे लाने के लिए वी सिंसियरली थैंक्स यूएनएस. सो मैम अगर हम आपसे बात करें तो आपने 8,000 प्रेगनेंसीज अब तक की हैं अब तक के अपने डॉक्टर करियर में तो क्या सच में आपको भी सिस्ट से इतना ही लड़ना पड़ा
Not every time, but of course, many of the cases I could say that I can quote it around 10%.
ओके 10% फिर भी बहुत वो है सो फर्स्ट ऑफ ऑल वेरी कॉमन क्वेश्चन मैम व्हाट एग्जैक्टली इज सिस्ट जो हमें पता चला है इट कुड बी अ सैक लाइक स्ट्रक्चर इट कुड बी फिल्ड विद फ्लूइड और इट कुड बी सॉलिड बट एग्जैक्टली व्हाट इज सिस्ट और बहुत तरीके के सिस्ट के नाम लोग लेते हैं तो क्या सच में इतने सारे नाम हैं इस एक सिंगल सिस्ट के
Gee, that's a very nice question. Actually, cyst is something, it's a thalla, like a kind of a balloon which is filled with water. So, where a space where water is collected is called a cyst. It can occur any part. For so far as we are concerned, is about the gynecological cyst. So it comes in multiple shapes, size, and like a combo pack even. So right now, like we have three different majorly categorized forms. One is a functional cyst, then we have a benign, and then a malignant. So functional is something that usually comes and goes. I mean, not to be worried about it. It is because of the disturbances in the hormones of ovulation. When your HPO axis that goes haywire, when suppose a follicle is something which is a egg surrounded by water. So when a mature follicle around 10th day of your 12th day of your cycle, it doesn't mature. So it becomes a cyst that is called as something like a follicular cyst. Okay, the water collects around the follicle and the egg is trapped inside. So it's a functional cyst. It's not pathological. It will go in the next cycle automatically without any medicines, or maybe if the medicines is required, it's just an OC pill, गर्भ निरोधक गोलियां. So if in
Right.
case if even the follicle ruptures and there is a collection of water, it is a corpus luteum cyst. Then if the blood is collected somehow, the blood vessels come and it enters into that particular cyst, it becomes an hemorrhagic cyst. So we have certain ultrasonologic criteria to differentiate between these are simple cysts which do not have any echo. Sound, ultrasound, we talk in terms of echo. Echo is the language of the sound. So we call it simple, eco free. There are no contents inside it. It's a water light. So it's all black colored and it's all, if there are certain gray areas are also maybe there. Then there can be sonolucent cysts, there can be solid structures which will be shown, there will be compartmentalization and chambers into the cyst. Like we can, if we cut a fruit and we find a chambers and the seeds are arranged, so that kind of, when you cut a fruit, any fruit, then it appears like that. So that can be also appearance of there are septations inside, so what we call as loculations, and inside small prominences of the tissue which we call papillary excrescences. So that usually we differentiate by a new terminology which we call as, in the language of ultrasound, aorta screening,
Yeah.
which is an international, yeah, international ovarian team of analysts. They have come with the aorta screening. So we have certain criteria for the cyst which will not become malignant, which are benign. They will need some kind of treatment, either removal or some medicines. But malignant, we cannot do anything. That has to be really followed and really treated. So, what is the benign and what is the malignant? Benign is something, they are simple, they are less than usually 10 centimeters, or even they are more than that, but that does not mean that there are certain other criteria. They do not have multiple septations or loculations. They are not divided inside by a curtain like structure, what we call as jilly or something, multiple, and their papillary inside their tissue prominences or papillations are not there. It is less, only one can be there which is less than 7 mm. And there, if you put in Doppler on that, then there will not be much flow in the Doppler signals, not blood much flow of. But and if the cyst on its pedicle, if it is having a stalk like structure, that the flower is held by a stalk, if the pedicle is like something, it goes rotation, it becomes a like this. So this is a torsion. So the blood supply will be cut. When the blood supply then becomes painful, and the ovary will undergo necrosis because there is no blood supply, it will
Yeah.
become gangrenous. So there will not be any blood flow in that. We put in the Doppler and we know how torted the cyst is, and that becomes an acute emergency. To unwind that torsion, then we need to detort it and try to preserve by laparoscopy or laparotomy, whatever suits the doctor, as much of ovarian tissue. If the patient is young and she is requiring fertility, if she wants to go ahead for further pregnancies, then we need to preserve that ovarian healthy tissue, and the rest gangrenous tissue we just remove. So this is a torted ovarian cyst. Then the most common these days, so first is the functional, where
Okay.
I have which is the follicular cyst, luteal cyst, hemorrhagic cyst, luteinized and ruptured follicle. They do not require any treatment. We just need to go for repeat ultrasonography. They are usually less than 4 centimeters, usually less than. They might grow, simple cysts might go up to 6 centimeter. That we should not be panicky about it. उसके लिए कोई डरने की बात नहीं है. बस फॉलो करना है। अगर आप दवाएं नहीं भी लेंगे तो वो अपने आप नेक्स्ट साइकिल में वो खत्म हो जाएंगी। अगर आप दवाइयाँ ज़्यादा से ज़्यादा गर्भ निरोधक दवाइयों की ज़रूरत पड़ती है। फिर एक कैटेगरी आता है हमारा डर्मोइड सिस्ट। Dermoid is a one cyst which is while during the formation of embryo, जब भ्रूण बनता है तो कुछ एम्ब्रियोनिक रेस्ट जो सेल्स होते हैं जिसमें तीनों लेयर्स हमारे एक्टोडर्मल, मीजोडर्मल एंड एंडोडर्मल सेल्स के जो रेमनेंट्स हैं वो उसमें रह जाते हैं ओवरी के अंदर और फिर वो ग्रो करते हैं। तो इसमें इस डर्मोइड सिस्ट सब बहुत कॉमन है। इट्स अ वेरी कॉमन स्पेशली इन द यंग पेशेंट्स एंड इसमें वेरी कॉमन स्ट्रक्चर्स विच आर विजुअलाइज एंड इट इसका अल्ट्रासाउंड में बड़ा खूबसूरत सा कॉटन वूल जैसा स्ट्रक्चर आता है। उसमें कहीं कहीं दांत वगैरह होते हैं तो वो शाइन करते हैं दो टिपिकली। तो ये जो कॉटन वूलिंग ये डर्मोइड होता है ये इसमें बाल के गुच्छे हो सकते हैं, ब्रेन की टिश्यू हो सकती हैं और दांत वगैरह हो सकते हैं। तो दिस इज वन अनदर टाइप ऑफ सिस्ट एंड इट माइट अंडरगो टॉर्शन। So you need a removal for this if it is a bigger dermoid and there a risk of torsion because ये rotate बड़ा कर सकता है, घूम जाता है, फिर वही टॉटेज हो करके गैंग्रेनस होके और सिवियर पेन हो सकता है। We can easily remove it by laparoscopy। फिर एक सिस्ट है हमारा जो ये सारे बिनाइन बिनाइन में हमारा कॉमन है डर्मोइड। देन वी हैव
जी,
serous cyst adenoma, mucinous cyst, epithelial ovarian tumors which we call as they might so we go by aorta criteria as I said. For malignancy the aorta criteria of ultrasound is that you have a solid ovarian tumor, more than 4 papillary excrescences, papillary projections as I discussed, and more than 10 centimeters in diameter. So this is something with all malignant features. So basic these four features of aorta. We have other criterias also. We can write a few patients certain tumor markers which may have some relevance, and that is cancer antigen 125, he4. Then other tumors, the type of tumors it will depend. If it is a malignant young female tumor will be dysgerminoma, then we have to write a beta hCG tumor marker. Then it may be yolk sac tumor. Then there are the two alpha fetoprotein can be a tumor marker. So basically for epithelial ovarian tumors, CA125 and he4, this is what we need to write to back up how apart from the ultrasound features. So malignancy we cannot help, we generally have to go for staging laparotomy if it is confirmed. And for these benign cysts and the cyst which just we cannot like which is really persistent and it's troubling the entire life, and which is a feature of endometriosis which we just cannot afford to miss, is a chocolate cyst. Why chocolate cyst? It is बिकॉज द जो बच्चेदानी की अंदरूनी सतह होती है, अंदरूनी परत होती है, विच वी कॉल एज एन एंडोमेट्रियम, दैट एंडोमेट्रियम स्टार्ट्स ग्रोइंग इनसाइड द ओवरी and that keeps on proliferating. So whenever the endometrium bleeds, that the endometrial portion which is lying inside the ovary, that also bleeds, so it will produce lot and lot of blood collection. And because of the backflow of the blood, usually the menstrual blood comes from vagina, but sometimes that is there is a retrograde flow. So that retrograde flow will spill through the fallopian tubes and go into the peritoneal cavity, and there the endometrial tissue gets implanted where it is not supposed to. And that every time whenever you have menses, that endometrial tissue will bleed, and so the cyst size may go on increasing. So the endometrioma is one. While we open it, we get a chocolate fluid, just like a Cadbury, and this is one cyst which is really persistent. But whom to operate and which are the right candidates for undertaking those tackling the chocolate cyst, this we have to decide. Many patients they might be having very painful menses. The menses might be really painful before the onset, and during like sex they may be having dyspareunia. Then the patients may have infertility associated with the size may vary from 4 to 10 centimeters, and it is very typical on the ultrasound. We have a like matte finish kind of ground glass appearance, that is multiple low level internal echo. As I told you, the echo is the language of the sound. This is how we express the sound, and ultrasound is a sound wave. So we get a multiple low level internal echoes, and it looks like a ground glass. And this is a chocolate cyst, and we need to differentiate beautifully by looking into all the, somebody who is doing ultrasonography, as we repeatedly do while diagnosing, we need to have a good understanding of the ultrasonology, that how the cyst will look on the ultrasound, and how it will behave clinically, and how it is going to impact the patient's life, how to tackle, when to tackle, how much time we have, what is the way we should consider for her furtherance, and how to undertake her. Either by laparoscopy, we have now laparoscopy, as you know, it's a boon, it's a vardhan for the gynecs, that we are just putting a keyhole and a scope and just doing the entire thing.
Right. And I
The
think it
recovery is
is
so
the
fast.
most powerful procedure in
Yeah,
treatment,
it's
gynec
a lovely
treatment.
thing. Yeah, it has revolutionized every treatment almost. Just like
Mhm.
ultrasound has revolutionized the diagnosis, similarly the therapeutic benefit as well as the diagnostic benefit, both the benefits has been conferred by this laparoscopy.
Yeah.
Because the
Right.
recovery is, you don't have to make your abdomen cut multiple times. Yeah.
Right. Doctor, we just talked about this different cyst, and do we really need to get rid of them or not? But again, the simple question is, cyst ho gaya, to what next? Do we really need a regular checkup, because ultrasound, medicines, and the daily visit to the center to check? And what you suggest, like, मेरा स्कैन हुआ, cyst निकला, what next?
या अगर स्कैन हुआ और सिस्ट है, अगर फंक्शनल सिस्ट है, so do not worry at all. It's a simple functional, it will automatically go. It's just simple ovulatory hormonal disturbances. ओवुलेशन हुआ नहीं, पानी भर गया, जो फॉलिकल के चारों तरफ था वो बढ़ गया, तो लूटियल में भी वही है कि वो पानी ट्रैप हो गया, वो बड़ा हुआ फॉलिकल, और नेक्स्ट साइकिल में वो डिसअपियर हो गया, या फिर हमने गर्भ निरोधक गोलियां ले ली, तो वहां से FSH हार्मोन का जो रिलीज है वो स्टॉप हो गया बिकॉज ऑफ द ओसिपिल विच यू हैव टेकन। तो वहां से कोई स्टिमुलेशन, कोई फायरिंग हो नहीं रही है, नो सिग्नल्स, नो हार्मोन प्रोडक्शन, सो एवरीथिंग सीजेस। सो तो अगर हमारा फंक्शनल है, हमें कोई घबराने की जरूरत नहीं, हेमरेजिक है, घबराने की जरूरत नहीं। 2 महीने के बाद हम, या 2 महीने का वक्त एटलीस्ट देंगे उसे कि वो रिजॉल्व हो जाए, और फिर हमें एक रिपीट सोनोग्राफी करके देखना होगा कि इट हैज रिजॉल्व्ड और नॉट। even sometimes there are certain cysts which persist, a cyst which is persisting and not going, and it is behaving very normal, that may be a para ovarian cyst, like fimbrial cyst, which is not, origin is not the ovary, origin is the adnexa. Some the all the structures which hold the ovary, like infundibulopelvic ligament, ovarian ligament, fallopian tubes, these are called adnexal structures. So the some with the water which collects inside, that becomes a para ovarian. You need to differentiate again. So these will not go by the hormonal therapy. Again, which I talked of, chocolate cyst. It's a very important, and the treatment for the chocolate cyst is like, it depends on your reproductive plans, your choices. What exactly are you really? Are these cysts are really painful? बहुत ही दर्द, दुख और परेशानी दे रहा है। संभोग के समय भी दर्द हो रहा है, और हमेशा यूं भी दर्द हो रहा है, और हमेशा मरीज जो है वो दर्द में ही है उसकी ज़िंदगी। तो अगर इस तरह से है, तो हम अल्ट्रासाउंड में बहुत ही आसानी से वो नज़र आ जाता है, और उसकी वजह से वो इर्द गिर्द की जितनी चीज़ें हैं, जो ब्लड जब भी मेंस्ट्रुअल साइकिल में, वो हर बार जो एंडोमेट्रियम स्टिमुलेट होगा और जो ब्लड शेड होता है, वो वहाँ से भी ब्लीडिंग उसमें जमा होती जाएगी, वो बढ़ता जाता है साइज, और अगल बगल के सारे स्ट्रक्चर्स को चिपका लेता है, क्योंकि ये एक इन्फ्लेमेटरी प्रोसेस है, एक इम्यून ऑल्टरेशन का डिजीज है एंडोमेट्रियोसिस। उसकी एक झलक है और उसका एक कह लें कि एक फीचर है जो हमें एंडोमेट्रियोमा के फॉर्म में दिखता है। एंडोमेट्रियोसिस का एक पहलू है ये, एक पहलू है जिसे हम जिसमें कभी ट्यूब में भी पानी भर जाता है और ओवरी में तो एंडोमेट्रियम ही है, तो उसमें वो ब्लीडिंग हो करके एंडोमेट्रियोमा बन जाता है। अगर एंडोमेट्रियोमा हमारा 4 सेंटीमीटर का है तो उसके ऊपर ही हम इसे एक्सेशन का प्लानिंग करते हैं। वो भी तब करते हैं जब हमारी पेशेंट यंग है और उसकी ओवेरियन रिजर्व अच्छी है और उसकी एएमएच लेवल्स भी बहुत अच्छी है, नॉर्मल है, बिटवीन 2 to 4 है या अबव 4 है, वट एवर इट कैन बी अबव 2, क्योंकि एमएच इसका बहुत अच्छा रिफ्लेक्टर है नहीं एंडोमेट्रियोसिस के केस में। हमेशा ओवेरियन एंड्रल फॉलिकल काउंट नंबर को कंसिडर करना चाहिए कि हाउ मेनी नंबर ऑफ स्मॉल रिक्रूटेबल एग्स during the just after the menstrual cycle. You have to count those and to write those in case of endometrioma which she is left with, and how much fast she is planning pregnancy, and whether there is any, if you are delaying the treatment, you are making the fertility clock like delayed. So
Right.
importantly, if you have an ovarian reserve, you can go for any cyst. If it is less than 3 centimeters, you should not touch the cyst because it's hardly anything to take out. If we take, because it's very important in the case of endometrioma to excise the inner tissue wall, you have to put a proper line of cleavage and excision of the entire ovarian, the cyst wall has to be done properly, and it should not come out piecemeal but in totality. Otherwise, what will happen, the cyst will again regrow, it will hit you back
Right.
again, and
Right.
there will be lot of recurrences again. It will come in a bigger size after some time. So in those cases we can plan a surgery when the patient is young, cyst is unilateral, she wants a pregnancy, she has good ovarian reserve, and her capacity, this thing AFC is very good, and she is having lot of symptoms as well. Then spontaneous pregnancy is achieved sometimes within 6 months of the surgery. So in the case of chocolate cyst, if the cyst is very big and she had already had few surgeries before, then we should not touch, we should must go for an IVF in that case. And if she had repeated surgeries before and there's still the endometrioma is there, because lot of adhesions and this thing with other structures is there, then we have dermoid we need to remove if it is a big dermoid, because no point keeping it, there is a risk of torsion, and suddenly she will land up in an acute emergency, and the ovary may become gangrenous, and why unnecessary push the patient towards emergency. If it is a
Right.
small dermoid, we can leave it like less than 3 centimeters, or we can just have a watch every 6 months, or every we can call her up for a follow up. If not very frequent, like 3 to 4 months, then at least 6 months she can be followed up, and we at least she must visit. For every year, a female should have a scan, just like a pap smear and all, to ensure her ovarian and this health, and utero ovarian health. Every year we should, ultrasonography is the simplest imaging, technologies have improved so much. Now we have 3D ultrasound as well, that
Mm.
depicts beautifully. We can pick up all good images, and we can very well know, and almost anybody can know under the sun right now. They are so very well versed with this technique of doing. So every year the females can get herself checked and ensure the ovarian and the uterine health. That is important. This is what I feel. And sometimes if she has already been having once or twice, she is having some cyst, then she can go for this. Then we have the epithelial ovarian tumors, which is a new growth inside the ovary. This is a new growth. Ovarian tumor is a new growth. So benign tumors and then the malignant. So
Many.
usually we have benign tumors. There's a long list of benign tumors are there. Fibroma, thecoma, fibroma in the case of menopausal females. Then we have some ascites in this case that secretes a lot of fluid, and that may go to the lungs. You might have a pleural effusion as well, which we call as the mixed syndrome. If it is from other kind of tumors like stoma ovarian, then we have pseudomixed syndrome. I mean, these kind of things are available. So basically, one very easy thing to remember is 1, 2, 3. One is the size of simple the egg which has not been matured, which is not matured enough. 2 is the size of the dominant follicle. When it becomes above 3, then it becomes a cyst. It's a collected water.
Right. So basically, first of all, visit your gynae, go for ultrasound, check exactly what is the size and what kind of treatment you really need. If doctor is suggesting for repeated scans, medications, then please do it because आप जितना टाइम सोचने में लगाएंगे हो सकता है आपका सिस्ट उतना टाइम बढ़ने में ना लगाए और बहुत जल्दी उसकी ग्रोथ हो। तो डॉक्टर पीरियड फ्लो से कैन वी मेक आउट कि यस सिस्ट हो सकता है लाइक अगर सिस्ट है किसी तरीके का सो इज इट
Yeah,
पॉसिबल हेवी फ्लो या स्कैंटी फ्लो आर दीज टू थिंग्स
very wonderful question that you have asked me. Hmm. Very nice this question, because what are the symptoms of the cyst? What are the
राइट
symptoms that cyst will offer to you and you will exhibit? Is the problems in the periods. Usually, the you might skip period, and you may have a heavy flow, or you may have a no flow. You can become amenorrheic. Period ही skip हो जाता है. So when the period skip, it can be like a ringing bell inside your head that you might suffer. The periods have skipped without with no rhyme reason. Then the other things can be you feel little bloating and जैसे भारीपन लगना lower abdomen में, या
लोअर
खाने के बाद अनपच होना, कुछ कुछ मतली वगैरह या nausea vomiting के symptoms आना, वेस्ट सर्कम्फरेंस जो abdominal size है उसका थोड़ा बढ़ जाना, then you can have belching, usually heaviness in the lower abdomen, and bloating phenomena. Then the periods related amenorrhea, skipping of the periods, and then having a scanty or a heavy period. It can be both. And then there will be some nausea vomiting associated. Then frequent urination, backache, पेशाब का जल्दी होना बिकॉज ऑफ द प्रेशर ऑन द ब्लैडर, जो सबसे आगे हमारे पेशाब की थैली है, तो वो होना, फिर बैकएक होना, कुछ ड्रैगिंग सेंसेशन होना, और अगर सिस्ट ट्विस्टेड हो गया जैसे मैंने दिखाया ऐसे करके, तो उसकी जो ब्लड सप्लाई कट हो गई, टॉटेड हो गया, तो वो अक्यूट पेन होना बिकॉज ऑफ द सडन apoplexis, sudden cut blood supply which has been, there will be infarction in the ovary and gangrene formation.
ओके
So
सो आई
these are the
थिंक
symptoms which then you need to consult your doctor and get a sonology done and establish whether something wrong has happened with you.
And I think here the very important thing is कि please treat your cyst very nicely and take it seriously. हम जानते हैं कि पीरियड फ्लो के बाद सिस्ट का चला जाना इट्स वेरी कॉमन एंड 80% ऑफ अस आर लाइक दिस ओनली ठीक है we'll see in next coming periods कैसे रहता है बट मेक श्योर दैट इफ दिस persists you should visit your doctor on time ऐसा नहीं हो कि डॉक्टर को सर्जरी की जरूरत पड़ने लगे एंड मेडिसिन का टाइम निकल जाए सो डॉक्टर सिम्टम्स हैं आई थिंक एक फीमेल को अपने आप को जज करने के लिए अपने रिप्रोडक्टिव सिस्टम को जज करने के लिए द बेस्ट थिंग इज पीरियड फ्लो स्किंटी है ज्यादा है पेनफुल है एंड एज यू सेड बैक एक एंड एवरीथिंग यूजुअली द क्वेश्चन अराइजेस ओवर हियर कि अगर हम चॉकलेट सिस्ट की सर्जरी में जाते हैं तो डॉक्टर हमेशा बोलते हैं कि about this, you have this window of 2 to 3 years. The possibility is that it may reoccur. So, what you suggest in such cases?
Yeah, we once we go for chocolates is I mean endometriotics, endometrioma surgery and excision. First of all, the first surgery should be the best surgery, and it should be in the best hands. And there has to be a complete cystectomy of the endometrioma. That is most important thing. Because if you're leaving the remnants behind, it is going to recur. Even if you're not leaving the remnants behind, the disease itself, inherent ability of the disease is to progress and to further form another cyst. That is the pathologic feature of the endometriosis. So, if the patient, we have to vehemently and try for pregnancy for further 6 months, because the best results of achieving pregnancy, the window of opportunity is 6 months following the surgery. There is like if we don't, then we can go for an IUI along with the because because the reason being for IUI along with this cystectomy is that because this is an altered immunity problem in the case of endometriosis. And because of this, what happens, even if the semen is going inside, that is phagocytosed, that is eaten up, that is scavenged, and the ovum is also scavenged. That is why we need to go for an IUI. It's better, we place it properly, the semen, and sometimes the altered peritoneal environment is all very bad to even in the milder diseases. The altered peritoneal environment, that is why they find it's not, it's subfertility, not equal to infertility, endometriosis, but
Mhm.
they might get harder time to become pregnant. All the patients are having harder time to become pregnant. So with
Right.
this cyst, it for the 6 months, I think I should be giving time or max to max 1 year, not beyond that, because we need to take, because the ovarian reserve goes on drastically declining and coming down, and with the, and I would not suggest repeat surgeries, because further if you do a repetitive surgery, what will happen? Whatever number of follicles she is having, which we expect to grow during stimulation, that will not, that will be all taken away along with the endometrioma excision. All that will come out.
Mhm.
So again, there will be a fall
No follicle.
reserve. So that is very important. And so for if she's not getting pregnant even after 1 year or 2 years, I think they should plan an IVF. The sooner the better. And somebody who's really not planning can go for an oocyte preservation, and you
Yeah.
know that oocyte preservation and egg banking. Yeah.
So, doctor, if someone with chocolate cyst is planning to go for IVF, so what course of action you suggest? Whether first stimulation, then laparoscopic surgery, or first surgery, removal of cyst, and then stimulation?
Depends upon the size and the extent of the disease, whether she is having a single endometrium or single chocolate cyst, or both the sides she is having chocolate cyst. If the cyst is size is very big, say 6 centimeters, and the follicle आगे की तरफ है कि पीछे की तरफ, जब हम उसको निकाल रहे होंगे, अगर पीछे की तरफ है तो वो कंटामिनेट हो जाएगा ब्लड से, और हम उसको
Hmm.
एक्सेस नहीं कर पाएंगे। वो डिपेंड, हमको उसको अल्ट्रासाउंड से देखना है, अल्ट्रासाउंड गाइडेड जब हम प्रोसीजर करके, जब उसको तो अंडे आगे की तरफ है तो वी कैन इजीली टेक इट आउट। सो लोकेशन ऑफ द एग्स अराउंड, एम आई ऑडिबल?
Sorry, नहीं आपका लास्ट लाइन नहीं
एम आई
सुनाई दिया।
ऑडिबल?
हाँ जी, अभी वी कैन हियर यू, बट
हाँ,
बिफोर दैट
जब हम, yeah, we have, first we have to decide whether the cyst is bilateral, how much adhesive the disease is, कितना वो चिपकन है उसमें, कितना उलझा हुआ है, कितना बड़ा है। अगर बहुत बड़ा है, मान लो 6 सेंटीमीटर का सिस्ट है, तो वो अंडे को उगने भी नहीं देगा, तो उसको हम सिंपली डिकम्प्रेस कर सकते हैं। जरूरी नहीं कि उसको हम बिल्कुल भी उसको जरूरी कि एकदम सर्जरी, सर्जरी भी इसलिए रिक्वायर्ड होती है कि जब अगर उसकी ओवेरियन रिजर्व अच्छी है, मान लो उसकी एमएच लेवल भी अच्छी है और हमें काफी अंडे चारों तरफ दिख रहे हैं, then we can undertake her for surgery if she's young patient. See, she has age to her side, because what happens that while we take her on for this thing surgery, then she might be landing with less value of AMH, and after the surgery, few months after surgery, and she may be having less number of follicles will be available. So best is to take the, we have to decide if the follicles are lying in front, then we can just do a good oocyte retrieval. If it is lying at the back beyond, then surgery might be required, because how will you access the follicle, and while access there will be a lot of contamination. And importantly, while we do this, then you should not inadvertently or just carelessly enter into this endometrioma that might result in invite lot of infections, and there can be ovarian abscess also. We're having some kind of a caution while, but we get good follicles even in endo, we get good follicles. The quality may be little compromised, but
Hmm.
With the we do the stimulation, make the embryos, freeze them all, then do good, give a GnRH analog to make to correct the entire environment, and the endometrioma also might go little lesser in size, and the uterine size, because this endometriosis is one disease which is also associated with adenomyosis. Adenomyosis is again the uterine layer inside the myometrium, with muscle layer of the uterus. The uterus will also grow. All those endometrial glands that will also bleed, and that makes the size of the uterus large. So you correct the peritoneal environment with the GnRH analogs, and then you do embryo transfer. After correcting all the aspects of the embryo transfer, the uterine size, peritoneal environment, the cyst size, and then she may land up into pregnancy. And there are certain instances where you need to go, and somebody who's gone undergone already a surgery should not go for a repeat surgery. And somebody who's there, like if the size is bigger
Ma'am,
and
excuse
accessibility
me.
is poor.
Just give me a second. चार्जिंग खत्म है लैपटॉप की. आप प्लीज कंटिन्यू.
Yeah. Agar if the size of the endometrioma is big and accessibility is also of the follicles is poor, then we cannot access. In those cases, we would try to like go for a surgery. And if she is having good ovarian reserve, then in that case, surgery can be undertaken to make everything best and optimize. So the outcome can be good. We get good M2 oocytes. We have a good access to the follicles, and we retrieve it nicely, and we don't have any problems while retrieval. And in that case we can go for surgery. Sometimes what happens when we take her up for embryo transfer, the cyst size may increase, and it becomes really painful then. So in that the judgment is important, and we have to be really prudent about how to undertake that case. The endometrioma, because it's an estrogen dependent tumor, and then we give lot of estrogens while like when we freeze the embryo and we prepare the endometrium, then it may enlarge in size, and it become really problematic for us to like curb the disease. Then that becomes a double-edged sword. So kind of that, and we need to have wiser decisions in that particular scenario.
Right. And doctor, is this cyst related to weight gain issues also?
Yeah, not, no, it's not related to weight. Is due to PCO. PCO phenomena is due leads to weight, and do endometrioma can occur in thin patients as well.
Yes.
Endometriosis is an immune disorder, immune alteration of the entire thing, and because of the retrograde menstrual theory, coelomic metaplasia theory, lot of theories are associated with it, and we have the back flow.
Right.
So
So, I think it's
basically, we
a kind
retrieve
of,
eggs. Okay, okay.
yes, yes, please, please.
You basically we consider the accessibility of the follicles. We retrieve eggs, make the embryos, freeze them, and then we do the transfer.
Right. So if you are thinking that yes, I'm not overweight, I'm not gaining weight, so that means my cyst is not causing any harm to me. So ऐसा नहीं है. Do try to visit your gynec, check again, do the ultrasounds, scans, whatever your doctor is suggesting, and it's nothing related to weight and cyst, but again, cyst at times is distorting your fertility things. So it's always advisable to treat the things. It's not advisable to seek information from Google. जैसे मैंने चेक किया कि इंडिया में 10 मिलियन केसेस हैं सिस्ट के. So guys, please don't do this. We have wonderful doctors in India who can guide you properly throughout this process. और अगर फिर भी लग रहा है क्लिनिक पर कैसे जाएं, किससे बात करें, तो प्लीज शेयर योर टॉपिक्स जिस पे आपको लगता है आप हमसे सुनना चाहते हैं, एंड वील डेफिनेटली प्लान अ वेबिनार फॉर यू. So, Dr. Imrana, thank you so much for this interesting session of cyst, because every time cyst है, so या तो वो chocolate cyst है या PCOD वाले cyst है, that's it. इसके अलावा हमें शायद वो तीसरा सिस्ट किसी को नहीं
नहीं,
पता।
पीसीओडी वाला सिस्ट तो अलग सिस्ट हो गया, वो
अलग
बड़ा सिस्ट नहीं है, वो मिसनोमर है। वो छोटे छोटे मल्टीपल होते हैं जिसमें अंडों की तादाद ज्यादा होती है, लेकिन वो मेच्योर नहीं होते टाइम पे, तो वो प्रॉब्लम है। इसको बोलो।
तो हमेशा अगर सिस्ट की बात करते हैं तो प्लीज ट्राई टू मेक आउट और कनेक्ट विद योर डॉक्टर टू नो एग्जैक्टली कि ये सिस्ट है क्या। इट कुड बी द रीजन फॉर योर इनफर्टिलिटी, इट कुड नॉट बी द रीजन। सो रीजन जानना बहुत जरूरी है। एंड अगेन डॉक्टर,
एग्जैक्टली।
अगर हम हर आफ्टर एवरी 6 months we go for regular checkup, ultrasound and all that, that will be very good for our health also.
Obesity, of course, if you are overweight, it is always detrimental to fertility in any way, with or without cyst. Any
Oh,
weight, which if weight has to be optimized in any condition to achieve good, like whenever you, even somebody who's having on optimum weight and without any comorbidity will achieve pregnancy faster than somebody who's really overweight. And weight also subjects you to multiple problems while your egg retrieval and all. Also doctors face problems for the overweight women because the access to the ovaries becomes difficult in that case. So usually what happens is, for the benign cyst we remove, like if it is serous cyst, adenoma, mucinous cyst, there are certain tumor markers. We can go by CA125. If CA125 is very much raised, that means if it is above thousands, then there is a pointer towards malignancy. Then we see we can add few other markers. We first determine किस एज ग्रुप का बंदा है, ये किस एज ग्रुप की है। अगर वो ज्यादा बिटवीन रिप्रोडक्टिव एज ग्रुप के 25 to 45 की एज ग्रुप में है, उसका 30 से, तो हम उसको एपिथेलियल ओवेरियन ट्यूमर में, फिर वो हम देखेंगे। अगर अल्ट्रासाउंड में पिक्चर नॉर्मल है, बिनाइन की तरह है, लेकिन CA125 बेशुमार बहुत ज्यादा बढ़ा हुआ, 1000-2000, तो हम उसे देखेंगे कि कहीं एपिथेलियल ओवेरियन मैलिग्नेंसी तो नहीं। तो हम उसमें एक दूसरा प्रोटीन देते हैं चेक करने, He4 देते हैं। वो लेस देन 70, मोर देन 70 आएगा तो फिर हम उसको उसमें कैटेगरी में लगते हैं। CA19-9 है, CEA है, कैंसर एम्ब्रियोनिक एंटीजन है। योग सैक ट्यूमर में अल्फा फीटोप्रोटीन होता है। डिस्जोमिनोमा यंग पेशेंट में होता है, बहुत ही गंदा लुक आता है उसका, सेप्टेटेड, बहुत ही बुरा सा। यू कैन जस्ट पुट अ स्कैन like your ultrasound and you can know if the patient is young, you can easily make out that this he is suffering from this. And beta hCG tumor marker उसमें बहुत बड़ा आता है, that strongly predicts and it's strong pointer towards the malignancy में हमें कुछ नहीं कर सकते, हम लेप्रोस्कोपी नहीं, हमें खोल के ही सब कुछ करना होगा। और फिर उसके बाद कुछ ट्यूमर्स होते हैं जो बॉर्डर लाइन होते हैं, जिसमें हम जो ट्रीट कर सकते हैं, जिसमें कीमोथेरेपी से काम चल जाएगा, उसमें जो रिमूवल से काम चल जाएगा, कीमोथेरेपी की जरूरत नहीं, दोनों के बीच में आते हैं। देयर आर सर्टेन ट्यूमर्स, so unless we subject tumors towards to pathology, we cannot know. But for benign tumors at least, because ovarian tumor एक ऐसा ट्यूमर है, ओवेरियन जो न्यू ग्रोथ होती है ओवरी में, वो एक ऐसा ट्यूमर है, वो देर से पता चलता है हमें। और
right.
हिस्टेक्टमी अगर हम कर रहे हैं किसी भी अबव 45 एज ग्रुप की लेडी में, फॉर अदर रीजंस, जैसे किसी को ब्लीडिंग हैवी हो रही है, किसी को ये एडिनोमायोसिस है, फाइब्रॉइड्स है, तो हमेशा ट्यूब्स को निकाल देना चाहिए, कि ओवरी को प्रिजर्व करना चाहिए। ट्यूब्स को निकाल इसलिए देना चाहिए कि सिरस सिस्ट एडिनोकार्सिनोमा जो बड़ा कॉमन ट्यूमर है, वो फेलोपियन ट्यूब के किनारे से उसकी शुरुआत होती है तो वो ट्यूमर ओवरी का, लेकिन शुरुआत
Mhm.
होती है फेलोपियन ट्यूब के किनारे के हिस्से से। तो ऑलवेज इट इज मैंडेटरी प्रोफिलैक्टिक सेल्फिंजेक्टमी टू बी डन while hysterectomy in all those patients who are undergoing hysterectomy for any reason, to get a tubectomy also done, but with the ovarian preservation, so that she may be safe. Mm. So this is one point which I just mentioned it by the way, in case of, yeah.
Right. I
और
think
ये
this
है
is
कि
very
अगर आप
important.
बिनाइन ट्यूमर है, जी,
Mm-hmm.
बिनाइन ट्यूमर है तो बहुत तरह के होते हैं, उसके मार्कर्स भी हैं। अल्ट्रासोनोलॉजिक एओर्टा क्राइटेरिया विच आई मेंशन्ड, उससे हम कर सकते हैं। तो ये सारी चीजों को मिला के हम ये तय करेंगे कि हमें कैसे कब लेप्रोस्कोपी से रिमूव करना है, और अगर वो मैलिग्नेंट है तो फिर उसको हायर सेंटर की जरूरत है कि कीमोथेरेपी, क्योंकि ज्यादातर ओवेरियन मैलिग्नेंसी जो होती है वो देर से डायग्नोस होती है। यही एक मैलिग्नेंसी है जो बड़ी डिजास्टर्स भी है और जानलेवा भी है और खतरनाक भी है, और कोई इसका ज़्यादा निदान नहीं, कीमोथेरेपी है, रिमूव भी कर दिए, फिर भी 5 ईयर सर्वाइवल रेट कम है। और क्योंकि इसमें बहुत सारे स्ट्रक्चर्स भी आपको मेंटम रिमूव करना है, यूट्रस भी एट द सेम टाइम रिमूव करना है, सब कुछ करना है, लेकिन ये बहुत खतरनाक साबित हो सकती है। इसलिए फिर ब्राका 1 एंड ब्राका 2, ये एक जीन है जिसको भी डिटरमिन कर सकते हैं। वो उस केसेस में हम जब देखेंगे, वो फर्दर वो एक हायर सेंटर का जो सारा चीज़ एक अम्ब्रेला है और जो सब कुछ कवर करता है, जब ये सब में ओवेरियन मैलिग्नेंसीज के एस्पेक्ट से। लेकिन नॉर्मल सिस्ट को हम बिल्कुल आसानी से डिटरमिन कर सकते हैं, लेप्रोस्कोपी इसको टैकल कर सकते हैं, बिनाइन सिस्ट को, और फंक्शनल को हमें छेड़ना ही नहीं है।
राइट। सो सिस्ट
फंक्शनल
है
सिस्ट
तो
को लेके
देखिए।
अक्सर ऐसी धारणा है, और बिल्कुल एक सिस्ट रिपोर्ट हो जाता है अल्ट्रासाउंड में, और सोनोलॉजिस्ट को उसको लिख के देना चाहिए कि दीज आर सम फंक्शनल सिस्ट, क्योंकि वो एकदम पेशेंट घबरा सी जाती हैं, और फंक्शनल
राइट।
सिस्ट को लेके वो एकदम वो जहन में बिठा लेती हैं कि अब तो कुछ हो गया बहुत ही पैथोलॉजिकल। वो तो बनता बिगड़ता रहता है, औरतों को कभी ना कभी फंक्शनल सिस्ट होगा ही लाइफ टाइम में। तो वो फिर वो नेक्स्ट में चला गया। मान लो जो अल्ट्रासाउंड नहीं करा रही हैं, तो उनको फंक्शनल सिस्ट हो रहा है कि नहीं, जस्ट बिकॉज वी आर नॉट लुकिंग and just seeing is believing, so we are not looking, that does not mean that she is not having any functional cyst. Menstrual irregularity के पैटर्न से भी हमको ये क्लिक होना चाहिए। कभी कभी menstrual बार बार एमेनोरिक होना, बार बार स्किप कर जाना पीरियड, तो फिर हमें एक अल्ट्रासाउंड और गायने से मिल लेना चाहिए कंसल्टेशन, कि भाई क्या वजह हो रही है ये, कि कहीं कोई सिस्ट तो नहीं बन गया।
सो सिस्ट है तो भी नहीं घबराना आपको। सिस्ट नहीं है तो इट्स ऑल गुड, बट प्लीज डू विजिट योर गायनिक फॉर रेगुलर चेकअप। इट इज रियली important to know what kind of cyst you are having and what kind of treatment you really need. अगर आपने मिस किया है तो प्लीज इस सेशन को दोबारा देखिएगा। सिस्ट के बारे में आई थिंक इससे ज्यादा वाइड सेशन हम नहीं ला सकते, बिकॉज सब कुछ इसी में है स्टार्टिंग से एंड तक। प्लीज डू चेक दिस अगेन एंड प्लीज डू शेयर दिस लिंक with your known one so that they can also know what exactly is this cyst. डरना है, घबराना है, या इसको साथ में लेके चलना है। एंड वंस अगेन थैंक यू डॉक्टर इमराना, थैंक यू सो मच फॉर ज्वाइनिंग टुडे। और आपने अपने हेक्टिक बिजी डे में से हमारे लिए टाइम निकाला। रियली अप्रिशिएट योर एफर्ट। थैंक यू
थैंक यू
डॉक्टर।
पूर्णिमा, थैंक यू,
थैंक
थैंक
यू।
यू सो मच।
Thank you, viewers, for joining today's session. Thank you.
थैंक यू।